welcome. We are so glad that you are joining us today here in July in this vacation season. And you are so privileged to have, I call him Father Rockstar, and that's not the only one. That is a name that circulates widely about our presenter today. And the reason for this topic is we were responding to the many of you that have responded to our survey. And this was the absolute top number one issue that everyone wanted us to address. So we're very, very fortunate that we do have the expert in this field to talk to us. So this is a two-part webinar. Today, we're going to address kind of the overview of mental health and how it affects people. And then the following webinar that we're going to do in September is going to address on how we minister to people that are affected by mental illness. So today we have Father Ragan Schriver, and Father Ragan is the Special Assistant to the President for Strategic Integration at Catholic Charities USA, and he's also the Assistant Professor at University of Tennessee in the School of Social Work. And he speaks widely on this topic, and we're fortunate also to have Ben Wortham on. Ben is the Vice President of Behavioral Health Integration for Catholic Charities USA also. I'm going to roll it over because there's so much that we want to hear from you. And I'll let Father Ragan explain about how we're going to be doing the format of today's webinar. But also always remember that please, as you are listening to Father Ragan, go to your chat feature and enter in questions, and then we'll be able to address those at the end of the presentation. So this is a webinar for you and to benefit your ministry. So please give us information as far as making sure we're addressing your needs. So Father Ragan, we are so grateful for the gift of your time, your expertise, and for your willingness to share with us today. So thank you.
Thank you, Karen, and thank you so much for what you're doing, your work, you and Jared, and thanks to everyone for the work that you all are doing. My very first job right out of the gate as a social worker was in an alternative sentencing program where I went into the county jail in Knox County, Tennessee, where I'm from, and did assessments, psychosocial assessments on the clients to make sure that they would be compatible with this alternative sentencing program. And it was a really intensive community corrections program. So that was my first thing right off the bat, and I just learned so much about the interaction between behavioral health and the environment in which people are from, and the political situation and the policy situation, and how many times the deck is just stacked against folks who have behavioral health difficulties and struggles, and how they have to interact with this whole system that's very complex and difficult to understand. So I'm just in awe of the work that you're doing and your willingness to give your time and effort to be able to serve people that really, I think that Jesus Christ is right there with the people that you're serving. And I hope you know without saying that Jesus Christ is with you, and you are Christ in so many ways to so many people. So I'm just thankful and glad to be a part of it. Well, today we're going to talk a little bit about the concepts around behavioral health conditions. And so I feel like maybe I have a little bit of a behavioral health condition, and that I might have a little bit of attention deficit hyperactivity disorder, because I have double booked myself. And so what I've done is I've asked my colleague and friend Ben Wortham to show a video of me speaking. I'm in the same spot, so it's going to be a seamless transition of me giving some thoughts and ideas that I have about the whole idea of mental health, the behavioral health, in relationship to the work that you all are doing in different prison systems and community corrections and county jails and all those things. So hopefully this is going to be some good general information just about the concept of mental health, and that how people suffer from these different conditions, and maybe some issues around some causation stuff, and then just to kind of get a bigger picture of it. And then hopefully, as you all are willing to chat in the chat feature, then we can see, or I can help see what some areas that you'd like more information about, or what specific things you'd like to find out more about that we can answer at the end of this session when I come back on. And then also for our next webinar that will be offered in September, that I can hopefully address things that we haven't completely addressed in this session today. So again, just super thankful, and I'm sorry that I've double booked myself. I didn't pay attention to my calendar and the time the time zone in which these things were in. So I'm going to jump over to another little thing that I have to go to, and then I'll be back in just a few minutes. But in the meantime, Ben is going to share his screen, and then you'll see me. Is it live or is it Memorex? And so so that'll be the situation. So there we go. So I wanted to share my screen here and talk through a little bit of a PowerPoint to help us understand the concepts that we need to kind of work with today around the issues that we're facing. And so you all have such an important work that you're doing, this job of meeting with and working with people who are engaged in the justice system. It's such a significant area of work. I mean, it's just so much where Jesus is, and I'm just so thankful that you all are doing it. So hopefully some of this information will be a supportive effort to your ministry and the important extension of the hands and face of Christ that you're being. So thank you just so much. So the title of this is called Behavioral Health Awareness. So you may hear the term mental illness or mental sickness or mental health or something like that, or even other negative terms that people use to refer to people who have struggles around the issue of behavioral health. But it's just something that I really want to make you aware that really this is a much broader thing than just the mental aspect of our life. So when we talk about behavioral health, which is a little bit of a more current term, so when you're engaging with other professionals around the people that you work with, then you may hear psychologists or doctors or whatever refer to this term behavioral health, which I think really is more encompassing of what people are dealing with. Because a lot of times, if there are malfunctions or difficulties or conditions that people are dealing with as far as their mental issues, it does impact their behavior, things they do, the way that they think, which is a behavior, the way they eat, what they drink, all that kind of stuff. So all that is engaged in this. So this behavioral health is really the issue that we kind of talk about. Okay. So one thing I want to kind of say is to start us off with, and this is the undergirding issue of the entire discussion. Here are two fancy Hebrew words, and you read it from right to left. So it's interesting. The top word is Adam-ach. Adam-ach. It's a Hebrew word. It's in the Bible when it was written in Hebrew, and that's the earth or the dirt or the world or the essence of the earth. Okay, and then this lower term is Adam or Adam. And so we know that in the story of creation, the second one, God took the Adamah, took the earth, took this dirt, and formed a figure and formed a human person and breathed his life into that figure. And that became the human, the human that came from the earth. So it's so interesting that linguistically, Adamah and Adam are so linked. They have the same core. So it's the same thing to think about us as human beings who have been given this gift of life. Here we are connected to the earth, and the earth isn't perfect. The earth isn't everything that it's all cracked up to be, but it's that spirit of God that's breathed into the earth. So many of us struggle with our earthly beingness and have difficulty with that, whether we have a physical illness or whether we have an emotional struggle or whether we're having a behavioral health condition. That's that kind of our connection to the earth, to the difficulty. But yet still within this great gift that we have of our body, our loving God has breathed his breath into us. And that even though we may struggle, even though our connection to this earth may lead us to have difficulties, there's still that spirit. And I think that that's the difficulty I think that you all have as ministers in this arena that you're in, is to be able to look through all that kind of connection to the earth, all that Adamah kind of thing, and really be able to see the Spirit of God in each and every single person that you're working with and that you're dealing with. And I think that no matter what, that's the biggest issue. So I feel like that no matter what I say today, that you all already know that. And I feel like that you wouldn't be in this ministry if you weren't already able to connect to people in this way and to recognize and to look through all the difficulties and be able to find the Spirit of God in every single person that you deal with. So I just wanted to underscore anything that we say today is this is the philosophy or the core issue that we're dealing with. So let me ask you this. Here are four things that we could talk about. These menses, brain tumor, junk food, and anabolic steroids. What do they all four have in common? Well, they've all four been utilized as a murder defense. Someone had a premenstrual syndrome, and she was used that as that she was not able to make had the proper mens rea to be able to make a decision for the actions that she was doing. Someone who had a brain tumor had gotten off of, and the same thing with junk food. There was the killing in San Francisco in the 70s. This guy used the Twinkie defense. You may have heard that for the killing that he was doing, and then anabolic steroids. Sometimes that can affect people, rage and those types of things, and then take people away from their normal decision-making process. So I just sort of wanted to point this out to just say, hey, look at these things that impact our behavior. They're all different things. There are things that come from outside, things that come from inside, things that are part of the person, things that are part of the person's environment. So when we talk about mental health conditions or behavioral health conditions, we talk about a complex picture of science and social science and psychology and physical health and all these things that come together. So it's a very complex picture. So we do the best that we can to try to help understand what is behavioral health and what are some of the conditions that can keep people from really living the fullest experience of the human life that maybe God is intending for us. So we've had a history of misunderstanding this. So let me lay out two examples of times when in our history related to mental health or mental illness or behavioral health that we've had kind of gotten it off the mark a bit. Okay, the first is this concept of the schizophrenic mother. You may have heard this term, but the idea was that back in the 40s and 50s, there was this theory that came out that said that it was the mother's fault that a child would end up with schizophrenia. And it was based on this concept of a double bind, that the mother was sending two messages to the child, all the time. So, I love you. I want to be distant from you. I want you to be close to me. I want you far away from me. I love you. I hate you. This kind of double message, something like that. The way that they talked about it was that maybe a mother would give the gift to the child, and then the child wouldn't use the gift for a while, and then the mom would say, "I gave you this gift, and because I loved you. Why aren't you using it? Are you hurting me by saying you're get like a double message that was there?" Well, this was the theory, and this is what everybody based their knowledge on, was this concept of the schizophrenic mother. In the early 60s, they did become very progressive and start to say, well, the father could have something with it to do with it as well. So really what happened then in the late 60s, early 70s, began to realize that it was not the mother's fault, as we know, that it's not just someone else's fault, that there is a brain chemical abnormality. What they did was they discovered that certain medication that helped people with Parkinson's disease may have another effect on other people with other behavioral health brain conditions. And so this was related around a neurotransmitter called dopamine. And so you can kind of see a picture here of what's going on with the brain and how there's maybe more dopamine, which is a neurotransmitter, available in the bloodstream than in other persons who do not deal with schizophrenia. So this is the idea that we recognize that this is a medication that can heal this. And we know this and we recognize because it's not a mother only, or it's not just that. So unfortunately, scientists who devoted their whole life to that concept of the schizophrenic mother being the origin of schizophrenia, and then realizing that it really is, it's a physical condition that is exhibited through outward behavior. So, and one of the things around it is this concept of the neurotransmitter of dopamine having too much or too much available in the bloodstream because of one thing or another. We can talk about all the intricacies of the nervous system around that, but it's a physical, response to something. Another thing that's understood around the concept of schizophrenia is a little bit not just about the neurotransmitters that are going on around in the peripheral nervous system, all the things that are in the peripheral nervous system, but also things that are going on in the structure, the makeup of the brain. So here on the left, you see a picture of a schizophrenic brain, and this is someone who has schizophrenia. And you can see those larger spaces in the middle. Those are ventricles in which cerebral spinal fluid is held. So inside those ventricles is where that is. Well, you see how much significantly larger that is on the brain of a person with schizophrenia than on a person that does not have schizophrenia. You see the ventricles are smaller. That's the typical presentation of that part of the brain. Well, then there's ideas like, okay, well then look at this change or this difference in the person's brain. That because the ventricle is so large, then that squishes other parts of the brain. So then that inhibits or any sort of production of certain neurotransmitters or certain thought processes. So some of the parts of the brain are sort of squished off because the ventricles are so large. And I say squished is a very scientific term. So I wanted to just point out that, look, there's a structural abnormality. So look,
in our history of trying to understand behavioral health conditions, we started off blaming somebody else, blaming the mom, and then realized, wow, this is a biological thing. And here we can talk about dopamine as being a real key element. But then we start discovering these things about brain abnormalities. So really, when we think about schizophrenia, or the schizophrenia spectrum is what it's referred to nowadays, this schizophrenia spectrum is more than just one disease. It's a multiplicity of disease. It's a multiple conditions. There's different ways that it's expressed. Through maybe there might be exhibited paranoia, there might be hallucinations that are olfactory, hallucinations that are visual, hallucinations that are auditory. And that's because there's these chemical things and aspects of the brain that are different than the typical person. And then all that shows that there's something going on biologically with the person. But all that biological stuff, in this case, is exhibited in behavior and the way the person interacts with the rest of the world and things like that. So really, it's a very complex situation. So that's just something I really wanted to point out to you, that I think sometimes we think we know what's going on, and boy, there's still more to the human mystery to try to understand. Another thing, I think, well, here's sort of the bottom line of it. We've got schizophrenia is the combination of genetic differences within a person, whatever environmental factors that may be at play, and then that leads to or combines to some neurodevelopmental abnormalities leading to the brain dysfunction, which can be diagnosed as schizophrenia. We know that schizophrenia really doesn't begin to exhibit until like late adolescence, early adulthood. We kind of correlate that with a couple things. A person may have a pre-existing disposition to having this condition, but then there may be some sort of environmental factor, maybe a trauma, or maybe something within the relationship in the person's life, and then maybe that combination could bring that out. It could bring it out. Another idea is that there's the front part of the brain, the prefrontal cortex, doesn't fully develop until a person is 25. So after that age of 25, then the brain is considered to be functionally, structurally pretty fully developed. But early on, we know that that's not fully developed. So maybe some of this may be correlated with the full development of the brain and the onset of schizophrenia. So this is a pretty serious condition when we think about it this way. So that's just to say that there's a lot of factors around this spectrum of disorders that we refer to as schizophrenia. Another area that's behavioral health disorder is that of what we've referred to as alcoholism. We currently call it substance use disorder. So when persons become addicted or have a significant habit formed around a substance that they're ingesting, whether it's a drug or whether it's a drink or something like that, or something that they're smoking. And so all those chemicals that we put into our body, we used to refer to them that say that somebody was morally weak, or that was a weak will, or that somebody didn't have good control of themselves, and that all that kind of stuff. And we'd say, well, go to church, go do this, do that, whatever, we'll punish you, we'll lock you up, we'll do whatever we can do. All that kind of stuff that was related to this. Well, we know now, kind of like the picture of schizophrenia, that there's a couple parts of the brain that really are involved in this. So when some people, when they consume a drug, alcohol or another drug, then we know that two parts of the brain in specific are really impacted. The ventral tegmental area, which I know is too much to remember, but like there's this portion of the brain that is about the reward system. So that drug is introduced, and it stimulates the reward system, making the person feel like, wow, I've gotten a reward. I feel really good. I'm feeling strong and healthy, and I'm feeling whatever. I'm feeling really good. I'm feeling euphoric, whatever that is. Then that begins to formulate, and the body gets used to that reward system going on. No wonder it feels so good. So then it kind of travels over to the nucleus accumbens, which is another part of the brain, kind of the extended limbic system, and that a nucleus accumbens is about habit formation. So that it becomes more about habit. And we can look at this when we see images of the brain, that when people ingest a substance that they may be addicted to or dependent on, then we can see that the blood flow around the ventral tegmental area. We know that reward system is firing off. The body's feeling really good because it's sending out messages to feel good. And then we also see that the blood flow going to the nucleus accumbens, and that it's reaffirming that habit. So then if you think about these two things are acting, and typically they're interacting with the prefrontal cortex, that front part of the brain that kind of governs what we do, that speaks to us about logic and about I should be doing this or I shouldn't be doing that, or somebody's going to get mad if I do that, so I better tell myself not to do it. And then we listen to it typically. But unfortunately, when a drug goes directly to those to the ventral tegmental area and impacts the nucleus accumbens, then the prefrontal cortex goes offline, and we're unable to make reasonable accommodations or reasonable statements to ourselves within the brain structure. So we're seeing this this big difficulty that then we see that somebody has really very little control over the idea of what's happening to them, because this something that's such a reward, it makes you feel so good, and then it's connected to such a habit that you can't help but do it. And then you've got this part of the brain that's usually governing your behavior and telling you what you should or shouldn't do offline and not engaging with you. So no wonder people have this serious condition, this behavioral health condition of substance use. It's significant. And then also with that is to look at the idea that engagement with the substance, and then there's that withdrawal, that then the body begins to depend on it. Like that reward system really does need it. It's almost like some cases that you need that reward thing going on in your brain, almost like you need air in your body. So no wonder people are doing whatever they can. I'd do anything I could to try to get air, as you would too. And so you think about that in relationship to persons with substance use disorders. So all this stuff about somebody being weak-willed or morally have issues, that has nothing to do with it as much as have a schizophrenogenic mother. That doesn't have anything to do with it. It's a biological issue that has external ramifications in the way that person lives and the way the person relates to others. So we're dealing really with a brain issue that has social, environmental ramifications. It's just so important to recognize that. Because then I think it helps me understand that when I have bad feelings or whatever, I know that, well, okay, well, maybe something's lighting up in my brain up there, it's okay. I mean, it's a part of me of being a human being. It's part of me being connected to this earth that I'm in. But I know that the Spirit of God is calling me to something else, and maybe I need to engage with other people to get a little bit of help about it. So that's part of the story. Look at this. You can see all the different things that are a part of what might cause a substance use disorder. And we think about these things that cause substance use disorders also being a part of depression, anxiety, eating disorders, other different issues that people face. And so we can see that there's a psychological, we can see there's stress that's external, we can see cultural issues, all the different things that are involved. And that's the picture for all behavioral health conditions. So let me ask you this. If you had this image in front of you and you had a pencil and you could only use 4 lines and not pick your pencil up off the paper, could you connect all of the lines in this square? Think about it for a second. Okay. Do you have an answer? Do you have an idea? The answer is this, that sometimes you have to go outside the box. And I think that that's absolutely true in our work and in your work specifically with persons that have behavioral health conditions, is that sometimes we just got to go outside the box. We need to kind of look at what's a new way of thinking about this. How can I understand this with this person? How can I really listen to this person in a new way? How can I be with someone in a different way? So I'm outside the box. Because if we had stayed in the box, we'd still be talking about schizophrenic mothers and morally weak-willed people, rather than looking at the science of what's going on and how we can really help people and look at a new way of living. So that's what's so important. And I think that's what's so unique about your ministry, is that you're taking it outside the church. You're taking it outside the confines of the church and bringing it to people who need it the most. Okay, so let me ask you a couple quick questions. How many people in the United States will experience a mental health condition in a year? 1 in 4, 1 in 8, or 1 in 2? It's actually 1 in 4. So 25% of people in the United States right now are struggling with a behavioral health condition. So that's a staggering number when you really think about it, that we're not alone. If you're dealing with something like this, to know that you're not alone. This is something that's a big picture. There's such a stigma around these issues, and thinking, well, I'm the only one, or I'm the person that's, in quotes, crazy, or I'm mentally ill, or whatever the things that we say. No, I have a behavioral condition, and it's impacting my brain. It's my nervous system is reacting in a certain way, and I'm one of many people that have this, and there's help out there for me to get, and I can do it. The second question: what percent of persons in state prisons, this is different than local or federal, but in state prisons have a mental health condition? You could guess 56, 25, or 18. Super sadly, it's 56, just over half. So you all know this better than anybody, to know that I think our prison systems have become often the new asylums of the United States today. So that's super sad to think that this is where we're housing people that have behavioral health conditions. It's higher number in local jails, like county jails and stuff. I think that because of the temporary nature of it. Then the third question there, what percent of persons in state prisons have schizophrenia, which is a psychotic disorder, as I was referring to earlier, and it has a prevalence of 1% of the general population. Is it less than 1%? Is it 3.9% or 7%? Well, it's 3.9%. So you think about it, almost 4% of the people in state prisons are dealing with this condition. Imagine that. Imagine that. Seeing or hearing things that other people aren't seeing or hearing in that very confined situation, being able to get access to good care, so many difficult things. What people I think in this condition need is somebody like you to just listen and to just hear them and to just be with them. Because I think oftentimes people feel so isolated or feel like that they don't have relationships, and then therefore that can contribute to depression. You know, persons with schizophrenia, really it's just like having diabetes or something. It's a physical issue, but it's manifested in this behavior that everybody else out there thinks is weird and scary and be afraid of. And there's movies about it and make us even more scared about it. But here you are interacting with this person. The greatest gift that you can give is your presence. Just to be there, to listen, not challenge the hallucinations, not challenge anything, just to be able to be there with the person. Quick story. I worked in an alternative sentencing program too early in my career in this. And so I was doing an assessment with a person, and he had gotten in some trouble. And so, but he came in with all his stuff. He had his suit on and had all his papers and this big briefcase. And so he said, well, I think I have radiation sickness. And how do you know? And he said he was hearing banging in his head. Well, I knew that was probably an auditory hallucination because that was what he was describing. It seemed to be the situation. And he said, well, I have radiation sickness because I can tell when I hold this, he got out of his box or his little briefcase, he got this metal detector. And so he said, see, and he held it up to his head and it was like ticking. And so it was ticking up when he held it up to his head. I think it was just the way that he was holding it. He said, see, hear that? That's indicating that there's radiation coming out of my head. Well, I thankfully just agreed and said, okay, I understand what you must be going through. This must be tough. Let's talk about how are you feeling about it? So I could get at the feelings around it, what the issue was. And then the psychiatrist dealt with the medication aspect of it. Well, I told the psychiatrist this and she said, oh, I forgot to tell you about him. The other caseworker challenged the hallucination and said, you know, that's not really radiation sickness. That's not what that is at all. And so he hit her with the metal detector. So that wasn't good. And then it ended up him being in more trouble. So I think if I could encourage you all, if you're dealing with folks and they begin to speak in patterns that are unusual or ways that are a little bit nerve-wracking or ways that maybe you don't completely understand, to just do what you can to just be present. Because that person oftentimes has ended up so isolated and so alone because nobody wants to hear the ramblings or hear the descriptions of things that are going on in their life or in their head, in their experience, that if somebody could just be with them, what a gift that would be. I have 1,000 stories of people that have schizophrenia, but then compounded with a comorbid experience of depression because they're all alone and they don't have anybody else in their life and they're all cut off. So I just think having someone like you to be present would be terrific. And the last question I wanted to kind of pose to tell us a few things is that persons diagnosed with mental health conditions in state prisons were twice as likely, 19% to 9%, to be charged with facility rule violations. Is that true or false? As you can imagine, and maybe as you've seen, it's true. So they're 19% as opposed to 9% of the general population of persons in prison are having to even have their terms or their sentences extended because they've violated the rules. Well, you know, if somebody is telling me in my head that I need to go against a certain rule or whatever, I mean, nobody would, no telling what anybody else says to me, you know, I might not go against it. So there's a big issue there. So that's just important to think about. These are the factors that we have to deal with. So here when we're thinking about behavioral health or mental health, good mental health is that generally I can think and do what I want and feel good about myself and be able to do what I need to do and to be able to accomplish all that. Sadly, on the other end, poor mental health is thinking or feeling or reacting can be very difficult. Feelings are tough, thinking and thoughts are difficult for the person, really or even really impossible to cope with. Can you imagine being trapped inside your own body and just everything in you is uncomfortable? Feeling doesn't feel good, thinking is negative, all that stuff, but you're stuck with yourself inside yourself. It's so hard to be able to deal with. So this great gift of being able to recognize what's going on. So if we think about this, let's look at it as a continuum. Not everybody is just, where is that line? Like, oh, they're sick, or oh, they're well. I think all of us have, it's like everything from the common cold all the way to pneumonia. It's the same thing with behavioral health, that I have, maybe occasionally I feel kind of down about things or frustrated with things, but then on the other end, maybe I feel really good and really excited about what's going on, whatever. But then the same thing can happen to someone, all of us. We all are somewhere on this continuum. And wherever that line is, who knows, and it doesn't matter. But to think about how important that is to recognize that there is a continuum to it. Now, on the far end of the continuum, here on this mentally unwell, I guess we could refer to it, is this book called the DSM. It's the Diagnostic and Statistical Manual of Mental Disorders. And so this is kind of the Bible. I've got it all. I teach classes on it and all this kind of stuff. But it's utilized to be able to diagnose someone. So in the prison system, it might be a little bit different. But I think if you have a diagnosis, then that might open up some opportunities for treatment that might not be there for you if in another case. I know, like in the more private or public sector, that if somebody has a disabling condition like one of these listed here, then you'll see that they're able to be reimbursed for their care through insurance. So insurance requires a diagnosis from that book, the DSM. So you can kind of see some of these are conditions that are described in full in the DSM. So say, for instance, anxiety is a common, fairly common behavioral health condition. Well, there's a chapter on anxiety disorders, and it includes panic disorder. It includes generalized anxiety disorder. And those are a couple of the ones that are in separation anxiety, reactive attachment. Those are included in the anxiety disorders. So these different anxiety disorders, we know that there are certain characteristics and certain things that you have to meet, certain benchmarks you have to meet to be considered to have that specific diagnosis. So say, for instance, if I was working with a client, then I would kind of look in my book here, and I'd look it up and see, well, do I think they might have anxiety? And then I would be able to look and see what are the different criteria to help me understand, does the person have anxiety or not? And that would kind of guide my treatment or guide the way that I worked with them in a more clinical or therapeutic setting. So the same thing with you guys. You don't really need to like know what all the criteria are, but if you understand that somebody's dealing with anxiety, you know that they're kind of feeling like they're falling off a building all the time, and that you've got that terrible rush feeling. Or if you know that someone has depression, then you know that they're really struggling with being down. It's more than just being the blues. It's that you're in a very dark pit, very difficult place. And in contrast to bipolar disorder, when you think about that, there are periods of time when you're at absolute mania, where just euphoria, mania, pressed speech, overactivated behavior, and then that will go along with periods of very low feelings and very low depressive moments. So these are the different disorders. I thought that today would be more general, and maybe next time we talk together, when I will be in there in person, I will not double book, then I will be able to talk a little bit further about some of these a little bit more specifically. One thing I think that we need to talk about specifically, or really just I wanted to bring out or pull out from all these things, all these issues, is that sometimes, no matter what the issues are, then that sometimes suicidal ideation, suicidal feelings, emotions related to suicide will pop up or might appear in a person. So this is something that's really, really important. So if you're a person and if you're ministering to somebody who's feeling suicidal, you might be scared or confused by how to deal with it. But really, I think the thing is to recognize that you're not alone, they're not alone. Many people think about this. How do I be present with a person in this moment? Of course, we need to talk to somebody else or bring in another doctor or bring in somebody about it, because that's something that we need to alert about. So some of the things that we would need to do is to do everything that we can not to judge the person, not to like make it more, like put a religious thing on it. Like, God doesn't want you to do this. That doesn't work. We know just we're not judging. Okay, thanks for sharing that feeling with me. I really do appreciate you sharing with me. You're important to me, and I want you to know that I would hate to see you hurt in any way. Talk to the person about how they feel, not how you feel. So it's really important to listen to what they're feeling. What are they feeling? Encourage them to get help. We're going to get help. I think that's the thing. I'm gonna let somebody know here that this is what's going on, and then to ask them how you can help. I think that's a big deal. I know that there are things that we need to do. We need to alert the certain person that this has been said to you. But then there's also that, how can I help? And I think when it comes to this, sometimes then when somebody mentions suicide, all the alarms go up, and then we're afraid to really listen to what is it that the person's looking for? What do they really want? And then whatever we can do to help them stay safe in this environment. Okay. So a lot of behavioral health conditions, as you can see there, like there's all these conditions, and I just wanted to bring out that one issue of suicide as being a life or death sort of issue that really needed to be addressed, I think. And suicidal ideation can appear really in any of these. Depression, eating disorders, that has the highest mortality rate of all, and really it's 1 out of 5 persons that die of anorexia die because of suicide. And then there are these others. Even schizophrenia spectrum disorders, persons often they're not violent. They're not typically persons with schizophrenia are less violent than the general population. So persons who do maybe engage in criminal violent behavior are fewer of those people have schizophrenia than in the general population, if that made sense. But when people do end up getting violent, it's usually with themselves, self-harm, or persons who have completed suicide, persons, typically it's a period when they've just started taking the medication, or when it's in a remission and they realize how life could be so much better than what it has been. And then when they think it's not going to end, then sometimes will die by their own hand. So that's a really tough situation. But I just wanted to highlight that for that reason. Then something else I wanted to say is that really in many cases, it's the stress response system that's gone off wire when we're talking about mental illnesses. That the brain is in place for a reason. We have this very complex way to respond to stressful things that are going on in our environment. And then sometimes that just gets a little confused. And so then that creates or leads to a specific behavioral health condition. Think about it in diabetes. Something in our body isn't quite right or the way that a typical person's is. So when we eat certain things, that it impacts us in a certain way. So it's the same thing with this. I've got this stress response system that's a part of my brain and part of my thinking and all that stuff. But then sometimes there might be something that comes in and that my body can't handle it or can't deal with it in a certain way. So then I begin to react in ways that are atypical and may exhibit in ways that might be fearful or alarming to another person. So when we think about the concept of stress is really a part of the thread of the conversation around behavioral health. And I keep using the example of diabetes, but I think it's a good one, that if you introduce sugar to somebody that's got diabetes, then how does the body going to respond or react to that? So in some ways, stress can be like sugar. It's an adversity to the body. But then the body is built to respond to stress. So sometimes it over-responds or sometimes it under-responds or however, because of some abnormality in the brain or the nervous system in some way. One important element in the understanding of behavioral health disorders, is stress and how stress plays a role. But another thing is the concept of attachment theory, which I'm sorry, that doesn't quite look right. But attachment theory, which really is beyond a theory really now. But this concept that the idea that when you are an infant, the minute that you're born, it's really important to have some sort of connection with another human being, typically the birth mother. In fact, when babies are born, there's an increase in oxytocin, which is a chemical in the body that brings about a sense of well-being and feeling good. The same oxytocin is elevated in the mother, and that brings that kind of unites them in a way. That is so important. The first 3 or 4 months of a child's life, attaching in a healthy way to an adult or a couple of adults or a group of adults in a way where they're held skin to skin, where there's visual contact. There are these neurons in the brain called mirror neurons, and that if we were reflecting those back and forth, it's so important. There's a thing, they kind of call it serve and return, that if I as a parent look at the baby and the baby looks back at me and then we're kind of giggling back and forth, or if there's baby sad, they're kind of sad back and forth. It's so important. Many people who are dealing with adversity in their later life had a really tough foundational experience of having a difficulty in their attachment process. And you can kind of see how different ways attachment impacts us, whether it's about proximity seeking in our relationships with others and anxiety around abandonment. Like, am I afraid that I'm going to be left alone? And how do I live that out? And those things are formed early on. I mean, newer research is saying, we used to think that, okay, up to 10 or 12 years old, that then all that attachment was really important. It is important, but that the first 3 to 4 months is significantly important. Think about this. You're a little baby and you're crying and you're hungry and you're miserable because you're hungry. And so you're crying and then somebody looks at you and then their face is blank. That baby is thinking, gee, I'm in all this suffering and no one cares. I'm alone and I'm isolated in this. I know that's a complex thing to tell yourself, but you get it emotionally. But if the little baby's crying and hungry and miserable, then the parent or the caregiver looks at the baby, oh, I'm so sorry. Oh, I'm sorry you're hungry. Let me give you this. Then the baby begins to realize, wow, my needs are valid. Somebody gets me. They're looking at me and not telling me to feel better. They just get me and giving me what I need. So that's so important for an infant to understand. And that just like is a foundational experience for somebody to build their life through their life. So that's just so important. This attachment issue we could go on and on about, but it's an important part of the picture of mental health, especially personality issues. Something else that we think about is the concept of a trauma experience in someone's life. I've spoken to many of you maybe before about the concept of how trauma impacts us. Well, if there's a negative experience, an adverse experience that happens in childhood or adulthood, our body, our stress response system, like I was talking about, evolves around the trauma. And then that can lead to anxiety, depression. So this type of stuff. Maybe my body might have been predisposed genetically to experiencing some sort of depression, but then introduce a traumatic experience, and then that's going to combine to lead out some sort of maybe a serious depression. We can't say enough about the brain, about how much the brain is really guiding all of this, all of these behaviors and stuff. So let me just say real quick, if we look at yellow, green, red, all those parts of the brain through evolution developed this way, from yellow, green, red, all the way up to the front. So maybe our ancient ancestors might not have had a very developed red part of the brain, the prefrontal part, but they had a strong yellow part. That's where all the heartbeat and respiratory functions and all that stuff happens. But then if we move into that green area, that's where a lot of the issues around behavioral health conditions exist. So the limbic system is inside that green area that controls emotions, the area that controls memory, the area that controls stress response, and also the area that sort of conducts a release of hormones into the rest of the body to tell the body how to react or feel. Those are all located there. So that's kind of a spot where some of the behavioral health conditions exist. Then you look at that prefrontal cortex, that red area. Sometimes that will, as it does in substance use, will kind of go offline in relationship to some of these disorders. So sadly, we go to therapy we minister to people, and we're using that prefrontal cortex, which is where the verbal part is. I'm talking to you head to head from a part that maybe isn't really connected to the rest of my body or my experience. So maybe when we're talking with people that have behavioral health conditions, we could play a game. We could engage in something else. I don't know if you can take walks or if you can do other things to try to engage other parts of the brain in your conversation and in your relationship with them. That could be a great way to just get around the whole idea that I'm just going to talk to you about a part that's really disconnected from some of my emotional life because I have a behavioral health condition. So that might be just something to think about. Could I play cards with the person? Could I play marbles? Whatever, just to kind of get other parts of the brain going while you're engaged with the person. Then that can create sort of a common experience with them. It shows presence with them, all those kinds of things. And I'm not sure what exactly might be prohibited in prison, but in working with folks. But maybe this might be something that you could think about. Let me say this also, that this is an important thing that goes along with all of this discussion of the issue. Look at that first slide there on the left. That's at birth. That's a slide of the neuronal connections, of the neuronal connections in a baby. There's very few. I mean, they're just born. They haven't had any experiences. They don't have any thing to rely on. Maybe they know they're hungry or know what they can sort of see or not see or hear. So there's that. That's the birth. But then look at 6 years old. Look how many neuronal connections there are. That's because kids are trying everything. They're going around trying everything new stuff. So they're developing all these new connections in their brain, new experiences, new stuff, new things going on, all this stuff, new stuff. But then look at 14. This is a process where there's been pruning. Some of the neuronal connections have been eliminated or have gone dormant. They're not active anymore. Some of the ones that are left behind have gotten stronger. Maybe you can see the ones that are left behind are darker than the ones in the other slide, but there are fewer of them. This is because some of the behavior has been reinforced by repetition. So when we think about some of the behavioral health conditions that people are dealing with, it's because they tried everything as kids, and then now, sadly, they've honed in on something that's maybe maladaptive or not in congruence with the rest of society or the way things act or whatever, or emotionally responsive to things that might be kind of negative. So those dendrites are grown and become stronger and stronger. Our job as ministers is to help some other nervous connections, neuronal connections to be made by being friendly, by being present, by being welcoming, by being with them in a new way that maybe they've never experienced before, a non-judgmental, unconditional, positive respect that you have for the person that might be there for them. And you can help them grow new neuronal connections in their brain. So this is what I think oftentimes happens with mental health conditions, is that that as the pruning begins, that the ones that the go-to neurons are the ones that are still a little bit unhealthy, or might be things that are not so positive for the person's experience. So that's kind of what's going on. So here's just a little bit of a picture of it. Here there may be toxic stress that goes on. It goes into the brain. It's processed through the brain. These neurotransmitters, some called cortisol, go out into the body. They impact body systems, impact the inflammatory response, and then even can reduce the physical response for wellness. And then that can lead to genetic expression alterations. So then maybe even some of these conditions might be passed on to children, to the offspring of folks. But that's not just to say that it's only internal and only biological. There's social elements. In fact, look at this thing that was studied. This is from 1939. We've known this for a long time. That mental disorders in urban areas. Look how the darker areas have more prevalence of persons with schizophrenia and other schizophrenia spectrum disorders in areas that are highly stressful to live in. So it's kind of interesting that there's an inverse relationship between social organization and schizophrenia. So that's kind of interesting because you can kind of see the exhibition of how many people might have this condition and how the social environmental factors impact them. So we can never just look at it, it's just the brain, although that's a key element, you can't get without it. But then there's also all these other social issues that are going on, and we've known that for a long time. So what about my role in all this? What about you guys in this? I think it's so important to care for ourselves. When we go to do our work or go to do our ministry, we need to care for ourselves and make sure that we're doing okay. We need to be all about thinking about options. What are options for myself? What kind of options, what limited options do I have to be able to engage with the person? Hey, would you like to talk about this? Would you like to talk about that? Would you like to pray? Would you like to just talk? Do you want to play a game, or do you want to, what do you want to do? So I think creating options is really important. I think also having the mind on a recovery, that things are going to get better, to have a hopeful mindset is really important. And I think this being able to encourage peer support is really important. I know that can sometimes be difficult in a prison system because of like what they call deviancy training. You get people together and they start talking about all the bad things they did, and they learn it from each other, and then end up kind of being more difficult. So that's kind of something to be aware of too. So really, I think this idea about managing conversations, we can think about really active listening is so rare in our lives, that really having someone listen to us, having someone care about us, having someone look us in the eye and do that mirror thing, the mirror connection, the mirror neuron connection, the serve and return that maybe somebody didn't get as an infant, maybe they can get it now and they could create a bond with you. That would be so awesome. How do I start this kind of conversation? Just to show your support, give control to the person as much as you're possibly able to do. Always keeping an open mind. And don't just talk about the person's mental health. Or just don't talk about think about a person's spiritual life as all aspects of who they are, not just their prayer life, or not just saying a prayer with them, but all kinds of things. And I think that bottom one is being patient. That's a really, really big one. It can be difficult. I know it's tough for me. Okay, and I think it's just a reminder to always be looking at your own self, looking out for yourself. The work you're doing when you go into a prison and you have that door closed behind you. I know that feeling. It's really tough and can be kind of scary or alarming. But I think just to do what you can to take care of yourself. You have a stress response system too, and it might go offline or haywire sometimes too when you're in these situations. But to be good to yourself, be kind to yourself. We're all human. We're all connected to this earth, as you can see drawn in the heart there. We're all Adama, We're all Adam. We're all human beings connected to this earth with that great spirit of God breathed into us. So I just want to say thanks for your understanding about having to watch this video. And hopefully I'll be able to connect and respond to some questions here in a little bit. So I really appreciate you all being here. And I am looking forward to talking to you more again soon.
Ben, I'm going to turn it over to you for just a second to see if there's anything that you wanted to add before we start asking some questions.
Yeah, Father is like, yeah, I mean, I feel extremely lucky to work with Father Ragan. Learned a lot from him. I'm sure a lot of you listening to that have incredible experience in this field. I'll just add, I worked at Catholic Charities New Orleans for 7 years, helping to develop a program that we enrolled homeless individuals who were using the emergency room. And so when I left New Orleans a couple of years ago, it was about 30% of the homeless individuals that we enrolled were recently incarcerated. And I just want to make just a couple takeaways from my own experience of what I saw. And so I had experience in homeless housing. And one of the situations that would happen is we would have clients, some of them we'd even meet on the streets, that had just gotten out of prison, were extremely sick. And I'm sure this is a problem everywhere because it's an affordable housing crisis right now. But you can't, and some of you might know this, you can't qualify for homeless housing, for subsidized housing, unless you've been homeless for 1 whole year with documentation. So the sick part about it is you literally had to have conversations with people like, hey, how long have you been homeless? Oh, 6 months. Okay, well, this is going to sound crazy, but actually, if you're homeless and you use the shelter at least once a month, and that's what you had to do in order to keep your documentation to keep your homeless status. If you stay homeless 6 more months, then you'll actually have a chance to qualify for homelessness. So that sticks with me today. And Father Ragan and I are working on an initiative called the Healthy Housing Initiative, where we're helping to develop homeless housing for the chronically homeless. And many of those moving in are going to have been incarcerated at some point. And that's in Portland, Oregon, Las Vegas, Detroit, St. Louis, and Spokane, Washington. And so the goal is to reduce chronic homelessness by 20% in those cities. And then another takeaway that I had, and I'm sure a lot of you are right there, is what was always interesting to me is when somebody was hit the streets after being incarcerated, the services available seemed to be getting somebody to help with employment. I know we had an employment specialist at Catholic Charities who would help. But one of the complaints from the employment specialist is that the people that were recently incarcerated were so sick that yes, the services existed to help find a job, but as he was telling us, it's like, we need a referral back to you guys to help with healthcare because this person's, we have the service for them right out, and but they're too sick to be able to hold down a job because they don't have a place to stay. So, and that's another thing that always really stuck with me. And then I'll just share one more thing is that we over the years had a lot of conversations with insurance plans because they have a lot of money to pay for some of these services. But what's really interesting is that in my experience, a lot of through these meetings with the Medicaid providers is they didn't want to pay for the services until the person had already used the emergency room, multiple times, maybe 5-6 times before they were interested in that person because they were a frequent flyer. But then we would always say back, if this person's enrolled in your Medicaid program, like the day they're released from prison, they qualify for Medicaid and they get on Medicaid, why does somebody who's recently released have to wait again to stay super sick before they can qualify? So I just wanted to add that was my own experience in relating to this topic. So thanks. And yeah, the recording will be available. Let's see if I can answer any of these questions. I'm not Father Ragan, lucky to know him.
No, thank you. Ben, thank you. And thank you for showing your passion. And there's no question once you have an encounter and you've seen, you can't unsee what you've seen. And I appreciate you addressing the issue, but we also need to, address this legislatively. And so
Yeah.
hopefully something that CPMC through advocacy and we as Catholics all coming together can work to change some of these laws. And so that people do have access. And I think the point that Father Ragan brought up is just, and we all, anyone that has entered or personally had a one-on-one contact with the homeless or with those that have been incarcerated, which there's a, as we all know, a high collaboration and a correlation in numbers, is that we lack as a country the support for the mental illness or mental health, behavioral health. I'm going to change that word in my vocabulary. Behavioral health needs to be addressed across the board, and it is such a high issue. I am hoping that Father Ragan is going to come back online in a second. He is preaching at the same time to SASSY, so our Catholic social ministers across the country are also, which we feel like we need to share him with. But as soon as he comes back on, I'm hoping that we can find out if there is some kind of a booklet or simple read that we can go back through this. We will want you to let you know that this video will be available. It'll be up on our website, and we will send it out again as a reminder before the second half of his video. So we probably, I know myself, I will be rewatching this so that I can get the full impact. We wanted you to have some time to sit with this, to be able to read, to study, we'll discuss it at our town halls, and to have an opportunity to kind of digest this information and then do a 1-2 with this presentation. So for a quick commercial before he comes back, I want to let you know that our next town hall is going to be July 22nd. And that is going to be, Father Zach Prosciutti is going to be the host for that. And we are going to be highlighting, because this is our reentry webinar, and that is the reentry program in Attleboro. And it's the St. Vincent de Paul, Attleboro is a St. Vincent de Paul operation. And so James Courtwright will be our presenter. And then in August, just an FYI, we are not going to hold the town halls during that time, but we will hold our scheduled webinar, which is going to be on August 11th. We're going to take a break in August due to the fact that it is, a lot of people are vacationing, and there will be a lot of transitioning back into schools, back into hopefully into institutions and prisons. And so during that month, we're going to take a break on the town halls, but the webinar on August 11th will address the legal challenges with immigration detainees. And so that's another key information. We need background information before we do this ministry and before have a complete understanding of what our immigrant population has faced or is facing, especially while they're detained. So, and then in September, we've got a wonderful lineup. In our first town hall will be addressing trafficking. And then our following Father Ragan's presentation will be dealing with ministering to our LGBTQ population. Father Ragan, welcome back. I hope it was a successful talk. We appreciate being able to share you. And I do have one quick question I'll lead off with this. Is there some simple booklet or simple read for people to, if they just want a little, to be able to digest it by reading or getting a basic understanding on a lot of the issues that you described today? Do you have a recommendation for a ministerial population or publication?
I would happily, if you wouldn't mind if I could email you a couple of recommendations that I have, but there's one that comes, and you'll probably think that he's selling his own thing, but there's a book, it's a social work textbook that you may think, oh gosh, I'm a minister, I'm not, but it goes through this book. I'll send you the reference. I can't think of the name of it off the top of my head, but I'll send you that reference, and you can get an electronic version of it, and it has little case studies that you could look at and see how would you interact with that. And so I feel like that might be a helpful one, but I've got some others too that I'll email to you and you can share with the group. I don't know if you have a listserv.
We do. We do, and we'll attach it to the email. We'll send it out also when we're sending out a copy of this video to everyone that's on the call today.
And I'm happy to share the slides as well.
Thank you.
Just the slides.
Thank you. That is wonderful. Do we have any other questions from our viewers that you'd like Father Ragan to address? In the chat feature, if you'll just look at it, in there's a lot of links. And so you can make connection with that as far as upcoming events. And also just to know, once again, that this is recorded and we will be sending it out again. So you have the opportunity to watch it. And we're looking forward to seeing you again at our our July reentry webinar. And that will be with Father Zach Prosciutti. He will be hosting an event on reentry from our St. Vincent, one of our St. Vincent de Paul programs. Father Ragan, thank you so much for taking the time to create this video for us and for everybody to utilize it. And we are all so grateful for just the gift of you and your ministry, your experience, and that you are training the next generation of ministers through your coursework.
Oh, thank you for working with me a million times, and thank you just a billion times for what you all are doing. It's so important.
Amen. Thank you so much for everybody for your ministry, and please reach out to us if you have any other questions or any other points that questions you want us to put in line for Father Ragan in his presentation for September. So thank you all. Thank you, Ben, for your assistance.
Yes, thank you.
Thank you, Father Ragan, and all of you be well and have a good summer. Take care.